Welcome, friends. This is Dr. Jaitly, your cardiologist from New York, on your favorite video site, MuniMeterHealth, where we have one goal, and that is to enhance education, both medical education and patient education, to our medical fraternity as well as to our patients at large, only to improve the clinical outcomes which have clearly been shown. And of course, that's been my deepest belief in my 40 years of some practice here in cardiology. And without any further ado, once again, I'd like to welcome you on MuniMeterHealth, which has been shown on several social platforms. So today's video vignette is going to be on risk stratification, specifically for syncope. Now, we know syncope is a transient loss of consciousness. So loss of consciousness, we'll write it here, and transient, obviously, because the patient regains consciousness fully without any neurological sequelae. Because if it's the neurological sequelae, obviously that's a cerebrovascular event. That's a CVE. But loss of consciousness with full regain of consciousness as well as no neurological deficit is considered as syncope. So that's your definition. I've done a couple of other videos which you can certainly find later on. But here we're going to be just talking about what's the risk stratification. Where is the need to hospitalize these patients for immediate further workup? Because obviously not all syncopes get hospitalized. Not all syncopes from the emergency rooms will get discharged. So if you're in the ER, now this is very good for the physicians who are in the ER specifically, and obviously residents, students, and fellows rotating in the ER. If they get called specifically to see these patients, this may be a quick brusher for them. Obviously, it's going to be on the boards as well. Where would you like to see these syncopes getting worked up? So best is to admit these patients, hospitalized at least for a day or two, and get these quick workups done. So this way you can actually decipher what's going on. Now, ascertaining on an EKG will help a great deal because one, you like to see, rule out the WPW. What is the WPW? Specifically for the quick students who want to brush up their skills here, a short PR. So you have a very short PR and then a prolonged QRS. Okay, and there might be a little delta here. So I'll just show a delta here if you like. So a short PR and prolonged and a long QRS. So with a delta wave, and there's a delta wave, and that is the WPW. So these are pre-excitation syndromes. Brugada classically is again present in a lot of Mediterranean and Southeast Europeans as well as Asian populations. So again, the suspicion is high, specifically if you're dealing with those ethnic groups. But the fact is that again, no ethnic group is immune either. So Brugada syndrome, where you get an ST elevation in the presence of right bundle branch, so and specifically so obviously in the right lead. So when you have say V1, when you're looking at, you will have an EKG will look like this, where the R are slurred, but then you have an ST elevation like this. So this will be a typical RS R dash prime with an ST elevation right here. Okay, so that'll be the Brugada. Short QT and long QT, of course, that's self-explanatory, where the QT could be either prolonged or QT could be shortened, if you will. Okay, if it is short, then obviously that's and again, drugs can do that. Remember, many beta blockers, calcium blockers, type 1A, procainamide, lidocaine, and all these drugs, which are not commonly used, but beta blockers are, and they will prolong. And again, electrolyte abnormalities, etc. So you have to look for electrolyte abnormalities here as well to look when you look for the QT prolongation. So I will just say drugs and electrolyte abnormalities here. They should be checked. So obviously these patients in the ER, so they're getting a blood test at the same time. Now, bi-fascicular block, especially if you have a left bundle, and I like to say the left bundle, sometimes you could have a right bundle with a LAFB, a left anterior hemiblock, or it could be left posterior fascicular block, LPFB. So again, it takes a cardiology fellow or a good astute internist or a ER physician to really look for these bundle branches. This way, you're very familiar with what's going on with the bifascicular blocks. Now, while we are looking at the EKG, also look for any sinus bradycardia, because the heart rate, if it's less than 50 specifically, that is suggested that something is going on here. That means the person was really dropping the heart rate inappropriately during the syncope and still has low heart rate. So there is some either sinus problem or AV nodal problem. Again, high-grade AV blocks, especially the Mobitz 2, the Mobitz 1, and of course, complete heart blocks. That's automatically admission right there. I mean, needless to be clearer on that. Non-sustained ventricular tachycardia and supra-ventricular tachycardia. That'll lend to support, because there you have clinched the diagnosis pretty much, because if you see these arrhythmias, you know what's going on. The syncope is related. That's 2 and 2, 4 right there. So, but in any case, in a nutshell, I've given you these arrhythmias and these various syndromes: WBW syndrome, Brugada syndrome, and then of course you have epsilon, where this is very important in ARVD. I forgot to mention about that, where there are negative T waves in V1 and V2. That means in the right ventricular, right anterior chest leads. There are epsilon waves. Again, these are slurred waves that you'll see, and there's the late ventricular potentials that have been defined in ARVD. What is ARVD? That's arrhythmogenic right ventricular dysplasia or cardiomyopathy. So where the right ventricle, the free wall, actually, let's draw that quickly for you. Here is your four-chambered heart, my favorite schematic. This is for the sake of the students, obviously. And here's RV, and this is LV, this is RA, and this is LA. Okay, so left atrium on the top. Now, this right ventricle normally is a free wall, obviously, which has a muscular component like the rest of the walls, like the rest of the heart, like the rest of the chambers. However, here you have more of fibrofatty. It's called fibrofatty tissue replacing the so that's replacing the myocardium. So if somebody wants to do a little biopsy here, the myocardium is being replaced by fibrofatty tissue here, which is replacing it here instead of the myocardium. So obviously this free wall is not moving too well, and that becomes very arrhythmogenic, and that's that can cause non-sustained VTs, even VTACs and VFs, etc. So people have died, and it normally manifests in young athletes, and because the right ventricle is so weak, it does not pump, eventually does not get the left ventricle output, really drops, and as the left ventricle output drops, the patient has a syncope and then collapse and maybe sudden death. So sudden cardiac death. Now, in history, remember, family history of sudden cardiac death is very, very, very important. If somebody's died suddenly, especially at the age of 30, 35, 40, you know, you look for coronary artery disease, you look for some arrhythmias, you look for long QT, short QT, because they could be transmitted in family history, and there may be clusters in certain genes. So you have to look for those, what you call channelopathies, if you will, and especially in a family history of sudden cardiac deaths. IHSS, again, remember that, if there is a history of IHSS in the family, or we call it hypertrophic cardiomyopathy. Again, those are very, very negative markers, I would say, if you will, in history, where one can say, look, this IHSS deserves more attention, especially so there has been an exertional syncope. Palpitations during the syncope will really signify that there is an arrhythmia ongoing. So certainly that gives a very good clincher as well. So these are very, very good clinchers for the history. Look for the electrolytes, look for the drug history, medication history, and of course look for illicit drugs too. Do not forget the use of illicit drugs as well, including cocaine and marijuana, and of course alcoholism. So I did not mention any of that, but I should say perhaps alcoholism here. That could be related to a very, very significant syncope. You could have cocaine use, and of course the marijuana. And the marijuana use is certainly very, very, prevalent, and now it's becoming legalized in many states. So you have to be very, very careful that people are starting to use it beyond recreationally, even for medical purposes. So you have to be very, very careful when you apply that for, say, of course, it's not FDA approved, but the fact is that people are starting to look into it and see if they can find a use medically as well. Anyway, so this was a quick, short video vignette on risk stratification for syncope patients. So those of who are interested in working in the ER or are rotating there, or as well as if you come across a case where a syncope has any of these salient features, like on an ECG there is an abnormality, or there's a documented history of coronary artery disease or heart failure. A previous syncope certainly is a negative marker, and then of course in the setting of ACS or AMI, just remember that somebody has acute coronary syndrome going on or acute myocardial infarction going on, then you have a syncope and you have troponins which are elevated, or EKG changes which are suggestive of ischemia. Then obviously that will require hospitalization anyway, but I've just mentioned that because there the syncope has a very, very negative prognostic indicator. Okay, so in short, risk stratification for syncope explains you the need for hospitalization and the immediate further workup that will be necessary. And of course, that we'll discuss some other time in a different video. All right, looking forward to seeing you guys again. Stay healthy, stay heart healthy, and stay well, and stay on MuniMeterHealth, your favorite video site. Until then, so long.